Hi, everyone, and welcome to our master's essay presentations. We have 4 presentations today. Each presentation will last about 10 minutes, and then we'll have opportunities for questions and answers. So our first presenter is Michel, who has a Bachelor of Science degree in biology from Indiana University. And her master's essay title is The Interplay Between Sickle-Cell Disease and Uterine Fibroids. And she's in the maternal, fetal, and perinatal health concentration. So Rachel, you can go ahead and share your screen.
Thank you for that introduction. Happy to get us started today. Okay. Let me know. Can everyone see my screen okay?
Yes.
Okay, thank you, Sylvie. So, okay, to start off, I will be walking you through my study. And it's important to note that I won't talk about every single analysis that I did today, just for time's sake. So I'm only going to present the most salient methods and results. So to begin, sickle cell disease is an autosomal recessive hematological condition affecting primarily African Americans in the US. Estimates suggest that around 100,000 individuals are currently affected in the US. Sickle cell is caused by a mutation which alters the shape of red blood cells, and it affects their ability to carry oxygen. It diminishes their ability to carry oxygen, which obstructs circulation in a process known as sickling. Sickling produces a lot of comorbidities in patients, including anemia, vascular dysfunction, organ injury, and what we'll talk about here today, tissue hypoxia, or low oxygen within the tissues. Further, sickle cell patients often experience reproductive health problems. Here are a couple outlined: pregnancy loss, menstrual pain or dysmenorrhea, and abnormal uterine bleeding. But overall, reproductive disorders in sickle cell patients are really understudied. Further, uterine fibroids are a benign gynecological neoplasm or tumor. In America, they disproportionately affect African American or Black women, with an estimated 80% of Black women being affected compared to about 70% of white women. The symptoms of fibroids are really multifaceted. The most prominent ones are AUB, or abnormal uterine bleeding, pelvic pain, incontinence, and difficulty in conceiving and maintaining pregnancy. So thus, the presence of reproductive issues among sickle cell patients kind of suggests to us, or to me, that the presence of fibroids might be higher in these populations. However, whether the prevalence of fibroids is upregulated in sickle cell patients is not known. So the purpose of this study is to examine the prevalence of uterine fibroids in sickle cell and non-sickle cell patients. So I conducted a cross-sectional study using aggregate data for patients seen at Johns Hopkins in their electronic medical record system, or EMR, and we examined the unadjusted and adjusted prevalence rates of uterine fibroids in sickle cell and non-sickle cell patients. Our study population included anyone who had an encounter at the Johns Hopkins hospital system. So this isn't just the downtown hospital, this is any hospital within the healthcare system throughout Maryland. Our study sample included those who were assigned female sex at birth, aged 18 to 65, identified as African American, and had their diagnosis or encounter between 2012 and 2024. Ultimately, we had 573 cases of sickle cell disease and over 460,000 without. For our study statistics, our method of association was the prevalence odds ratio. This was appropriate due to the cross-sectional nature of our study, which included prevalent cases. We also used the chi-squared test of association, the Cochran-Mantel-Hansel test, and we reported the prevalence odds ratio with the Cochran-Mantel-Hansel weights, as well as the Breslow-Day test of homogeneity. So in terms of our study sample characteristics, we found that the average I say we, this is my study. I found that the average age of patients with uterine fibroids in both sickle cell and non-sickle cell patients was older than those without fibroids. And this makes sense due to the age-related risk of uterine fibroids. Further, we found that most of our study sample was non-Hispanic and had never smoked. In terms of results, our unadjusted analysis showed that there was a statistically significant increased likelihood of developing uterine fibroids in sickle cell patients. So you can see that outlined at the top of table 2. So that produced a POR of 1.55. When we adjusted this analysis by age, we also found that in every age group, the odds or the likelihood of fibroids was increased in sickle cell populations. However, this was only statistically significant in the 36 to 50 age group. And this also makes sense because this age group has the highest prevalence of fibroids in the general population. Further, the p-value for the Cochrane-Mantle-Hansel test was statistically significant, indicated that we could reject the hypothesis that sickle cell status and UF are unrelated within age groups. The POR for the Cochrane-Mantle-Hansel test was 1.91, which again showed that once we adjust for age, the relationship between sickle cell and UF was stronger. And lastly, the Breslow-Day test of homogeneity revealed a p-value of 0.9, which means that we also reject the hypothesis that the association differs within age groups. So moving on to the discussion, the associations we found between fibroids and sickle cell, again, I'm saying we, this is all me, may be due to mechanistic links between the pathology of fibroid development and sickle cell disease. So sickle cell disease, again, is a disease of reduced ability to carry oxygen. And this hypoxia is known to induce inflammatory angiogenesis, which is essentially the formation of new blood vessels. And we know this because sickle cell patients often present with higher rates of endothelial growth factors, such as VEGF and TGF-beta. And essentially, these are a class of molecules that have a fundamental role in the process of new blood vessel formation. Further, this hypoxia-induced inflammatory angiogenesis also modulates immunological responses within patients with sickle cell. So in patients with sickle cell often present with increased levels of cytokines, such as interleukin 4, 6, 10, etc. And cytokines are essentially small proteins that signal that your immune system has been activated. Further, angiogenic growth factor dysregulation is also implicated in fibroid pathology. So hypoxic environments have been demonstrated to induce angiogenesis in fibroid cells. And so patients with fibroids also display increased rates of these angiogenic growth factors and cytokines, making me believe that it's possible that overactivation of these inflammatory pathways due to the chronic hypoxia that sickle cell patients have may contribute to fibroid pathology. Further, I believe that the blood transfusions may play a role in development of fibroid pathology. So over 60% of patients receive at least one red blood cell transfusion per year, and many receive more. And blood transfusions have been shown to demonstrate the immunomodulatory effect, which means that it can stimulate the body's immune system. Many studies have noted increases in both cytokines and angiogenic growth factors following blood transfusions. Thus, it's possible that the elevated level of cytokines and growth factors that we note in these patients may play a role in fibroid pathology. So this is an exploratory study that contributes our knowledge to a really understudied area of knowledge. However, there's limitations to note. Number one, it's cross-sectional. We included prevalent cases, so it does not permit causal inference. Number two, our data set is de-identified and aggregate, so we were not able to confirm diagnosis with access to imaging. And third, it's a single center study. Hopkins is one of the best places to receive treatment for both fibroids and for sickle cell. So it's possible that we have higher patient populations with both of these diagnoses, possibly biasing our sample. In conclusion, we found an association between sickle cell and increased likelihood of fibroids. I speculate that it's possible that fibroids are missed in sickle cell patients because pain from the fibroids is attributed to pain from the sickle cell. So due to the results of the study, it may be of value to increase pelvic screening and imaging for uterine fibroids in patients with sickle cell disease of reproductive age. Here are my references and any questions. Should I keep sharing my screen? For the
You don't have to. Sorry, I was having trouble unmuting myself. Perfect timing and great presentation. Excellent analytical models. Do we have any questions for Rachel from the group? Mara, keep your hand raised.
What recommendations do you have for future research in this area?
So because again, this is a preliminary or cross-sectional study, future research that is able to access more of a comprehensive data set that could have individual level patient data, have access to imaging, have access to hemoglobin electrophoresis data. This would all just contribute to more rigorous methods in studying this. Sickle cell patients are kind of hard to identify, so there's some limitations in using a database like this. So I would say repeat the study with a better database.
Are there questions for Rachel? Rachel, I was wondering, what was your rationale for selecting the age groupings that you chose, particularly? I know you talked about your area of interest is reproductive health, and choosing the older age group, the 51 to 65 group.
Yeah, so choosing the whole entire age group of 18 to 65, typically for fibroids, that is the area that or the age that you see fibroid development. It's really unusual to see patients develop fibroids before 18. And it was difficult in selecting, or we put some thought in selecting an age group because sickle cell disease is a disease of accelerated aging. So we were not entirely sure how we could totally match sickle cell to fibroid, but we ultimately selected based on when we see fibroid diagnoses in the general population, which is between 18 and 65. Did that answer your question?
Yes, I'm part of it. And just, I know that did you consider additional age groups, like 4 or 5 age groups, or kind of how did you end up with the 3 that you chose?
Oh, that was based on previous literature.
Okay.
I looked at another study using the same tool, and they had identified those 3 age groups. So I just based it off their methods.
That's a good way to do it. Very nice. We have time for about one more question if anybody else has
Nicole has a question online.
Oh, sorry, Nicole, I didn't see you. Go ahead, Nicole.
Great, thanks, Emmy. So I've been working as a part of a clinical trial for gene therapy for sickle cell for the past couple of years. And I was wondering if you've seen any changes in the literature for women who have had gene therapy to correct their sickle cell disease. If you haven't, that's totally fine. I know it's kind of like a new realm, but I'm just curious.
That's really interesting. I don't know. I haven't, I'm more in the fibroid side than on the sickle cell. This study really introduced me to hematology and that work. But I have not seen any changes based on gene therapy. I know in my literature search on reproductive disorders in sickle cell patients, it's very sparse, and it's a really sad state of literature for examining any reproductive disorders, but that is an interesting area. I just don't know about it. Thank you.
Thank you.
Great questions, everyone. All right, well, thank you so much, Rachel. Great job. We are going to move on to Colby. There's Colby. Okay, Colby Mallett has a Bachelor's of Science in Biology from Loyola Marymount University. Her area of interest is also maternal, fetal, and perinatal health. And the title of her master's essay is Disparities in Cervical Cancer Prevention for Black Women. So go ahead, Colby.
Thank you so much, Erin. It'll be hard to follow Rachel's amazing first presentation, but I'll do my best. So hello, everyone. As mentioned, my name is Colby Mallett, and I'll be presenting my master's essay titled Disparities in Cervical Cancer Prevention for Black Women. I want to quickly acknowledge and thank my reader, Dr. Pamela Donahue, and my advisor, Dr. Mary Catherine Augustine, who for both of their support. Okay, so my essay format was the analysis of a public health problem. This presentation will briefly summarize my work and will flow from background to causes and determinants to alternative interventions and a conclusion. I'll start with some background so we're all on the same page. So the big question, what is cervical cancer? Broadly, cervical cancer is a cancer that begins in the cells of the cervix, most frequently in the squamo-columnar junction of the cervix, as you'll see here boxed on the right. This is the junction and a border where the endocervix or internal area and ectocervix or external area meet. The two most common types of cervical cancer are squamous cell carcinoma, which develops in the ectocervix cells, and adenocarcinoma, which develops in the endocervix cells. Due to its nature, any person with a cervix can be affected by cervical cancer. And as a disclaimer, I will be referring to the at-risk population as women, as that's what's used in current literature. So how does cervical cancer develop? It all begins with small changes in the cervical cells, just defined as dysplasia. When these small changes go unidentified and untreated, they develop into cervical cancer. On the right, you'll see a healthy cervix and then a cervix with dysplasia present. This is what physicians are looking for as a precursor to cervical cancer. Now, cervical cancer is almost exclusively caused by persistent high-risk HPV infection. With 99.7% of cases being caused by infection, HPV is called the necessary but not sufficient cause of cervical cancer. So we use screening to identify the dysplasia and then staging to quantify the cancer severity if it's present. Current screening aims to identify dysplasia and precancer cells in the cervix prior to its development into cancer. Now, early detection could significantly increase a person's chance of survival. Early detection yields about a 91% survival rate, whereas late detection yields just a 19% survival rate. So the Pap test is typically performed during the yearly pelvic exam, which is recommended by ACOG. It involves collecting a few cervical cells to be examined further for dysplasia. The screening begins at 21 years of age, regardless of sexual status, and then every 3 years from 21 to 29, and every 5 for 30 to 65. An additional HPV co-test is recommended with the Pap test for only women over 29. So onto the magnitude of this public health problem, and specifically the severity of the racial disparities. Just to look at prevalence to start off, I want to make it very clear that Black women historically and currently report the highest incidence and prevalence of cervical cancer of all racial groups. The current age-standardized hysterectomy-corrected mortality rates are 10.1 per 100,000 for Black women, which is the highest rate amongst all groups, and more than double what we see in white women at just 4.7 per 100,000. Black women also report the lowest 5-year survival rate for both squamous cell carcinoma and adenocarcinoma at every single stage. So previous estimates of this disparity actually significantly underestimated the prevalence in Black women by not correcting for hysterectomy status, as Black women commonly report the highest percentage of hysterectomies in all racial groups. This increase was seen across rural and urban settings, and the hysterectomy correction also challenged previous data that was reporting a decline in cervical cancer after the age of 65. One study found the higher corrected incident rates for all age groups above 65, and that percent change from pre to post correction ranged from 77% to 97% in the oldest age groups. So onto some causes and determinants of this problem. So knowing now that HPV causes nearly all cervical cancers, it's a clear starting point to look at where these disparities are arising from. The CDC reports that the prevalence of HPV, both high and low risk, is highest in the non-Hispanic Black population for men and women age 18 to 59. This increased prevalence is associated with several factors that differ significantly between Black and white racial groups, namely lack of knowledge or awareness surrounding HPV. One study found Black participants to have 30% lower odds of HPV awareness than white participants, with many reporting not knowing that HPV is a sexually transmitted infection. Other factors include lack of provider recommendation, earlier sexual debut among Black girls and boys, and a higher number of vaginal sexual partners. Additionally, among the Black women age group between 15 and 25, they were 43% less likely to be vaccinated when compared to white women, and Black Americans were found to be less likely to complete the entire vaccination series after initiation. Now, HPV vaccination effectiveness increases substantially with series completion. So even within this group of vaccinated people, Black individuals are still at a higher risk of infection. So these clear disparities in HPV infection and vaccination are actually reinforced with similar themes in cervical cancer screening. In terms of screening, current efforts to expand access have been proven ineffective as the percentage of women being overdue for screening continues to increase. It was 14% in 2005, increased to 23% in 2019, and was just recently exacerbated by COVID-19. Several reasons are noted for this as well. Again, namely the lack of healthcare provider recommendation, lack of knowledge, competing priorities such as work or low income status, lack of insurance, health insurance and cost, with each of these reasons being more prevalent in Black women when compared to white women. So these inequities in HPV and now screening as well ultimately lead to Black women presenting at a later stage. Black women were found to be 34% more likely to present at a more advanced stage than white women, and were the most likely out of all racial groups to present at the most advanced stage. Late stage of presentation means the cancer has progressed in severity, options for treatment are limited, and survival is less likely. So now alternative strategies. I'm going to pair some examples of current strategies with my own recommendations. The first is community-based education campaigns. There's a current campaign going on from the CDC called the Inside Knowledge About Gynecologic Cancer. This campaign is aiming to address the education and provider recommendation gaps, as mentioned before, by improving both patients' and providers' knowledge of Pap tests and HPV screening for cervical cancer. But when we look at creating effective interventions that mitigate racial disparity specifically, it's imperative to account for mistrust, particularly in large systems like healthcare. One study exemplifies this by using trusted community leaders, in this case, religious leaders in South Carolina. This faith-based approach recognized a large religious population and found that nearly 67% of Black adults in the area attended church. They investigated the use of the church as an education space. Preliminary results actually showed that most participants felt that the church was an appropriate setting for HPV and cervical cancer education and felt that youth involvement would be beneficial. The religious leaders who were not willing to discuss sex or HPV were still willing to discuss cervical cancer in the space. More community-based interventions could be effective in both ensuring the population at risk is met where they're at and making them more likely to change their attitudes or behavior surrounding HPV vaccination. Now, my next strategy is very simple. National recommendations should expand to address racial differences in HPV exposure and risk. Age guidelines should start earlier and end later to accommodate for Black girls' younger sexual debut, which leaves them at a higher risk for infection at a younger age, and older Black women over 65 who have the highest cervical cancer mortality rates. This early debut and high mortality rate are not reflected in the white population. Therefore, a large population of Black women are actually outside of the risk, are outside of the confines of screening eligibility and are at risk. Finally, I would highly recommend future research efforts to focus on racial disparity, specifically identifying the methods that are most successful in minimizing them. The multifaceted nature of HPV infection and leading to cervical cancer makes several places to intervene. It's imperative to find which one leads to the most poor outcomes. Insurance coverage is one consistent factor that influences HPV vaccination, cervical screening, and treatment. One study on nearly 24,000 cervical cancer patients found that insurance status mediated more than half of the racial and ethnic inequities in the diagnosis of advanced stage cervical cancer across all racial and ethnic minority groups when compared with white women. Structural level factors like insurance are very difficult to change, so new research focused on mediating these disparities is needed to facilitate in insurance and other structural factors like national vaccination and screening guidelines or funding allocated to these groups. I briefly highlighted some groups that mitigate cost and that could receive more funding with increased data here. So my conclusion is very brief. If you can take something or anything from this presentation, let it be this. Cervical cancer is almost entirely preventable. Public health and healthcare professionals alike have a responsibility to address and prevent the inequitable incidence and death rate experienced by Black women in the US. And that's all.
Great job, Colby. You also stuck in your time and did a very nice job. Okay, so we have about 5 minutes for questions. It looks like Sylvie has a question for you.
Yes. Hi, Colby. Congratulations. That was awesome. I have a question because you likely don't have an answer, but I was just curious because as we know, or as many of us may know, like HPV isn't something you can really screen for in men. So I was curious if you had any thoughts about when you were talking about the implications of using church as that space for those discussions, if men or boys would be involved.
From what I know from that specific, it was just only one study that was actually doing this, but in the South Carolina study, they were involving men, youth in those spaces. So it was basically the church youth as a group, as a whole, that they were trying to involve. And the acceptance was from religious leaders and parents.
Cool. Thank you. That was really awesome. Thank you.
Great question, Sylvie. Are there other questions for Colby? Dory, looks like you have a question.
Great job, Colby. That was awesome. I had a question. It was one of your first solutions regarding the church intervention and how there was feedback that they wanted to include youth more into the education in the churches. And I was wondering if you could just expand more on that and tell me a little bit more about what they found and how they wanted to involve youth.
Yep. So they were, like I a little bit mentioned to Sylvie, they were using youth who were already involved within the churches. And the reason why that is so important is because vaccination is recommended for 11 to 12-year-olds. So a lot of the hesitation comes from the parent side, with parents not giving permission for youth to get involved. So it kind of both empowers youth to feel, in charge of their own health and in charge of asking their parents and learning more about what HPV vaccination means. And it was giving parents the information to make what they felt were educated choices. And there was a lot of data reporting that using trusted leaders in the community as opposed to healthcare workers actually found that there was more of an impact in changes in attitudes and behavior.
Thank you.
Great. Emmy, I think you're next.
I think you're muted, Emmy.
It's because I always forget to unmute. Thank you. Thanks for a really interesting presentation. I really appreciated the way you sort of talked about individual level factors and then traced them back up to the structural. I have a question about insurance, though. Is there any research to sort of look into the content of coverage or the continuity of coverage in different insurance regimes? I'm thinking about, does somebody get a physical, or does somebody have, every periodically and so on? If there's continuity of providers that might be tracking or seeing somebody frequently, or things like that might, it's not so much having the insurance, it's what the insurance provides, I guess.
Yeah. So I'm not too sure about continuity of a single provider, but I do know that it was the status of insurance coverage, the lack of awareness and knowledge of HPV vaccination included not knowing that you were covered for HPV vaccination. So this idea of cost being a huge barrier and a primary barrier for a lot of people in screening and vaccination is actually something that is really easily mitigated by just education. Medicaid covers vaccination, all HPV vaccination recommendations. And there's programs for children under 21 and under 18 specifically, which is, far after the recommendation. So that would be an easy barrier to kind of address with just a little bit of education.
Yeah, and it strikes me that maybe EMRs are a way of sort of getting over the continuity of care issue because it's there, right? Anyway, thank you.
I think we have time for one more question from Rachel.
Hey, Colby, great presentation. You really pulled it together amazingly. So for your recommendation, I know that the study with the youth and involving the church or community leaders, I know the study referenced was in South Carolina, which to my understanding is more of a state that has a little bit more interconnection between church and state, which is why people were responsive there. I don't know, did you think about maybe in places where a church wouldn't necessarily be as appropriate, but for I'm thinking of more northern states or, not Utah or not southern states, where what type of replacement you could use instead of a church to still involve community leaders, or if they're more responsive to that than medical professionals?
Definitely. So just to note that South Carolina study actually was working so well, they expanded it to a little bit larger of this Bible Belt area, and it's working in other states. But there are studies we'll call it more northern states that are actually using schools as a way to increase HPV vaccination in children. And one of the studies actually found that parents were 97% in agreement that that is an appropriate intervention. They felt that it was not okay for schools to offer HPV vaccination at the school setting. So using other people like teachers or schools, or even just community health workers or community head leaders in the community, I think would be definitely a beneficial place to start.
Fantastic. All right. Thank you so much, Colby. We are going to move on to Claudia's presentation now. So Claudia Paszek is another one of our MSPH students. Her area of interest is in population and health. And her Bachelor of Arts degree in Psychological Sciences is from the University of Connecticut. And the title of her master's essay is Gaps in the Family and Medical Leave Act and the Need for Paid Leave Expansion in the United States, a legislation position paper. So Claudia, go ahead and get started.
Thank you so much for the intro. I'll get right to it then. All right, so I'll first start off by providing a background on the FMLA, relevant gaps in equity regarding access to FMLA benefits, what we can learn from paid leave expansions, both internationally and domestically, and then finally presenting a bill currently circulating through Congress, which is called the Family Act. All right, so I'll start off a little bit with some history. So with the outbreak of World War II and military conscription of young men, many women were required to join the workforce for multiple reasons, one of which was supplementing family income. And at the time of the conclusion of the war in 1945, women made up about a third of the workforce. However, it took nearly 40 decades for there to be policy advancements that supported pregnant workers. And though 3 bills failed to pass through, the FMLA successfully passed through legislation under President Bill Clinton in 1993. But by that time, the proportion of women workers had actually nearly doubled. So the FMLA that we know today guarantees eligible employees up to 12 weeks of unpaid job protected leave per year with continued health benefits. The leave covers personal or family illness, family military leave, but most notably for this presentation, the birth of a child. Despite its benefits, though, the FMLA's eligibility criteria exclude many workers, including part-time, seasonal, and gig economy employees. Also, the lack of paid leave creates financial strain for many families during crucial times, which can worsen health outcomes for parents and infants. This highlights the urgent need for a comprehensive paid leave policy in the United States that covers all workers, ensuring they don't have to choose between financial stability and health. However, I'll first go into the gaps in the FMLA a little bit more closely. So from what we can see, the FMLA promises much, but often falls short, in particular for low-income families. The stringent eligibility criteria requiring 12 months of service and over 1,200 work hours exclude many low-wage workers who typically hold irregular or part-time jobs. And this limits the FMLA's reach and also deepens the economic vulnerabilities of those most in need. So we see that recent data shows that only 38% of low-wage workers, which the study I took this from defined it as those earning under $15 per hour, they are eligible for FMLA benefits, only 38%, and top earners are more than 2.5 times as likely to have access to paid leave. With single-parent families, who are often headed by single mothers, they're also particularly impacted. Among mothers who took unpaid leave, 50% of them were service workers. And this is important to consider because single mothers are disproportionately employed in sectors like retail and hospitality, areas where family leave is less likely to be offered. Additionally, 68% of parents that needed leave but didn't take it, which is referred to as unmet need for leave, reported making this decision out of fear of job loss. Lastly, with women of color in the US, they face considerable obstacles regarding family leave policies that heighten their vulnerability to economic strain and adverse health outcomes. Recent data reveals that FMLA eligibility for people of color stands at 44 to 48%, which is actually lower than the national average of 56%. This issue is also particularly salient for Black women who often are primary earners in their families. And then moreover, Black and Hispanic individuals are twice as likely to face unmet leave needs compared to white Americans. And these issues in particular are especially worrisome considering the fact that Black women experience a maternal mortality rate significantly higher than the rate for white women. In fact, 20% of deaths among Black women that resulted from maternal suicide are linked to factors like insufficient maternity leave. So while the FMLA has provided essential job protection for families caring for newborns, its shortcomings are quite clear. Restrictive eligibility criteria and the lack of paid leave have significant implications for both economic security and health outcomes. Access to paid leave allows individuals the necessary time to recover properly from childbirth and prevent premature return to work, which can exacerbate both health problems and financial burdens. Moving on now to the expansion of paid family leave. So one visual I really wanted to share was the staggering fact. The US is the only high-income country in the world without paid family leave. In fact, as we can see, a very small minority of countries do not offer paid leave on a national scale. So why does this matter? Well, as an example, Sweden is recognized as the gold standard for paid family leave among high-income countries. And when we compare its policies with those of the United States, research reveals significant disparities in maternal and child health outcomes. So for instance, the infant mortality rate in the US is at least twice that of Sweden, and about 39% of the excess infant mortality in the US is attributed to high rates of preterm births. So the lack of antenatal leave in the US has been linked to a threefold increase in the risk of preterm delivery. Additionally, research has shown that these lower infant mortality rates are associated with paid leave expansion, both internationally and domestically. Various US states, starting with California in 2004, have implemented state-level paid family leave policies. California's initiative, which now provides, I believe, 8 weeks of paid leave post-birth, has demonstrated substantial benefits, particularly for Black and Hispanic mothers who saw a tremendous increase in leave utilization, improving from previously using just 1 to 2 weeks of leave to 4 to 6 weeks after the policy's implementation. Recent studies also highlight that California's paid leave has led to improved breastfeeding rates, timelier vaccinations, and fewer infant hospitalizations. These health benefits have been particularly pronounced among historically vulnerable groups, proving the large effect that well-structured paid leave policies can have on community health and well-being. So why not just leave it up to the states, right? If everything is working so well? Well, unfortunately, significant racial and ethnic disparities in access still remain. So for instance, in California, women of color receive significantly fewer weeks of full pay during parental leave. Black women receive 3.5 fewer weeks compared to white women. So what we need is a national paid leave policy that could reduce these disparities by setting more inclusive eligibility criteria and extending benefits uniformly across all groups. So introducing the Family Act. Before I go into it, though, I'll first explain, during the pandemic, the US implemented the Families First Coronavirus Response Act, which offered caregivers up to 12 weeks of paid leave to tend to children affected by pandemic-related school or care facility closures. However, this initiative concluded in December 2020. So inspired by the success of that bill, the Family Act was introduced to Congress first in February of 2021, with an updated version recently introduced in May of last year. And it aims to provide families with 12 weeks of paid leave, as well as remove excessive obstacles stemming from FMLA, which prevent numerous Americans from accessing essential leave. An overwhelming majority of voters support a model similar to the Family Act, and actually nearly 650 organizations have already nationwide urged members of Congress to support the bill. So in conclusion, in the face of ongoing changes in reproductive health policies, such as those post-Dobbs, I recommend and really urge congressional leaders to support this bill. Americans deserve assurance that their country will support them and their families, both health-wise and economically, So with the strong support for the Family Act, legislators should prioritize its passage to demonstrate their commitment to putting families first. Yeah, just wanted to say a quick thank you to my reader, Dr. Emmy Hughes, all PFRH faculty, staff, and students, and family and friends for supporting. Thank you.
Great job, Claudia. That was so interesting. I love this topic personally. I think many of us on this call probably feel passionate about this. So thank you for outlining everything for us. Are there any questions for Claudia? So maybe since you ended on the most recent legislation that was introduced, could you talk a bit about kind of what sorts of opposition you've heard for this piece of legislation, and kind of, I know you don't have a crystal ball, but what do you think is going to happen, and what are the next steps?
Yeah, that's a great question. There has definitely been a little bit, as we can imagine, even historically, previously with FMLA, there was a lot of pushback from conservative leaders, given the fact that there are concerns about maybe its financial burden on the US and the US budget. But I think what is really promising is that there are many initiatives to kind of help push not only just the Family Act, but similar bills forward. For instance, there was recently a coalition developed called it's a bipartisan group that is hoping to kind of push more on information on paid leave. So it's both Republicans and Democratic leaders kind of jointly discussing the topic. So there's definitely some promise and hope for this moving forward. But yeah, it's definitely still a bit of a concern. So I think primarily what we see is mostly female leaders pushing these types of bills forward. Yeah, so.
That's great, thank you. Do other people have questions for Claudia?
I do. Because I know, this Pat, like with your field placement, and more recently you've wanted to venture into more of a policy space. That's been this interest for you. What was the biggest challenge of taking more of your quantitative brain and moving it into more of a policy space to write this paper?
That's a great question. Definitely was a new venture for me, as I'm sure Emmy can also speak to. But what I really enjoyed out of it was being able to, because I still get to use my quant brain of taking in all this information from the studies and then being like, okay, what story can I weave with this? And how can I share this eventual goal of us needing to address the gaps in the FMLA? So that was definitely a really great way for me to learn how to work in this policy space and try to be persuasive in that way.
Well, I think you did a really good job of telling the story, and I like how you went all the way back to World War II. I think that definitely contextualized a lot of what we see now in terms of policy and history. So great job.
Thank you.
Okay, we have some time for another question or two if anyone else has a question for Claudia. I mean, it's always just mesmerizing that so many other countries do this well, and then that we are so far behind,
Oh, I guess I should raise my hand.
Oh, go ahead, Emmy, that's fine.
I was about to speak. When Claudia gave the information about the US as like one of a handful of countries that doesn't have anything. I mean, I really was like, is this true? I thought it was I thought it was like a miswriting, like one of the only, I know about the high income part, but I didn't know about the rest of the world. I mean, I should know, but so that was just amazing to me. Now, my question for Claudia is, do you have any sense of how well the people who support the Family Act are bringing in the health issues? Because those seem pretty compelling from, your presentation and also your.
God damn it.
Yeah, so from what I have seen, I think there has been mostly focuses on financial and cost, because I think that's
Right.
where
That's where
a lot of the pushback comes from. But what I have seen, especially in the fact sheets that the people working on the Family Act have put in together, they do include the points about maternal health, which are really important, particularly maternal mental health as it relates to unpaid leave. So, yeah.
And also the children's health, because that strikes me as like
Yes.
hooked. Yeah.
Yeah, absolutely. Yeah, infant health.
People
as
may
well.
not care about moms, but they may care about children, she said,
Babies.
in a
Mhm.
completely blunt way of putting it.
Yeah, especially the points about infant mortality. The fact that we're even able to see that there are correlations there is really important, and I imagine that they are from what I remember seeing. So
Definitely. Great. Well, thank you again, Claudia. That was really nice. And thank you for all the questions. And so we just have one more presentation left. I feel like this has flown by with such interesting talks. So our last speaker is Sylvie Wilson, and her area of interest is women's sexual and reproductive health. And Sylvie has a Bachelor of Arts degree in neuroscience from Pitzer College. I should have asked you how to pronounce that. Is that right? Pitzer?
Right.
Awesome. And her essay title is A Qualitative Exploration of Experiences Related to Receipt of Pre-Abortion Ultrasound in the United States United States Crisis Pregnancy Centers. And I heard a bit about crisis pregnancy centers in the news this morning. So this is another very timely talk. So go ahead.
Awesome. Thank you for the intro. Thanks for everybody's awesome presentations. My name is Sylvie, and thank you for sticking with me to the end. Yes, so my presentation is I focused on a grant proposal for my master's essay. So this is a proposed qualitative exploration of experiences related to receipt of pre-abortion ultrasound in the crisis pregnancy centers that we just referenced. Sorry, I always don't know how to press next on this. So just a little bit of background. To start off, I'm going to talk a little bit about telehealth abortion. And telehealth abortion is the use of medication abortion that's prescribed through telehealth. So there are 2 or 1 type of medications prescribed for an individual to undergo an abortion at home or just not in the clinical space. And these abortions are medically safe and effective. Prior to the coronavirus pandemic, individuals who wanted to undergo a medication abortion did telehealth or otherwise had to receive an ultrasound. But during the pandemic, it became apparent that simple screenings through just a few questions could actually identify the risk factors that those ultrasounds were looking for. So that's ectopic pregnancy and the duration of pregnancy. But despite a lack of medical indication, a lot of individuals who are undergoing telehealth medication abortion are still seeking pre-abortion ultrasound. So now we're going to hop over to my field placement. I did a field placement at Advancing New Standards in Reproductive Health, which is based out of UCSF. And when I arrived there, I learned that there's a gap in understanding the location and reasoning behind these pre-telehealth medication abortion ultrasounds. So I used data collected by Answer and UCSF through the California Home Abortion by Telehealth study, which collected data from 3 major telehealth medication abortion facilities, for lack of a better term, to start answering some of these questions. So what we found are the following 3 key points. Firstly, patients are largely choosing to receive a pre-medication abortion ultrasound. So of 190 individuals or participants who did receive 1 or more ultrasounds during their journey to medication abortion by telehealth, only 10 were referred by one of those 3 houses to go get that ultrasound for potential indication or being medically indicated. So individuals were more likely to obtain a pre-abortion ultrasound if they were younger, so younger than the age 25, experiencing food insecurity, had less than 4 years of a college degree or education, and were unemployed. And then ultrasound occurred most frequently at clinics and hospitals, but a good chunk of the participants were receiving care at crisis pregnancy centers, which really stood out to me, and I'll explain to you why. So you may have seen some lingo like what's listed on the right-hand side before. These are typically signage and things that we've seen, but a lot of people don't actually know what a crisis pregnancy center is. So I want to talk about that. A crisis pregnancy center is a nonprofit organization. Tons exist across the United States that are typically religiously affiliated, and they are not clinical spaces. And they typically will suggest that they provide reproductive health care, but they do not provide comprehensive care. So they might potentially provide ultrasounds, condoms, and potentially more like advice, but there's no clinical care that's treatment there. The background or the foundation of crisis pregnancy centers is largely anti-abortion. So studies have found that the methods that are used at crisis pregnancy centers increase stigma for individuals who are going in for an abortion or to find out where to receive an abortion. So that could look like gaining misinformation about the abortion process, about spontaneous abortion, about birth control, and then also on the other end, offering more money or services or free things to individuals who continue to carry on their pregnancy. And then these crisis pregnancy centers appeal to underinsured individuals because they are free, and Black and Brown individuals and underinsured individuals are more reliant on CPCs, but it's also been found that crisis pregnancy centers from here on out, I'm going to refer to as CPCs. It's also been found that the crisis pregnancy centers will market and advertise to these groups specifically. So all of these different factors create barriers to timely abortion care for patients. And in terms of ultrasound, which as I referenced, there might be opportunity, that might be one of the few services that they offer, that doesn't mean they're doing these services well. So as I referenced, the individuals who work at crisis pregnancy centers are largely non-clinical staffers, and they don't necessarily have training to conduct an ultrasound. So data has shown that they may state clients have missed the cutoff date for abortion, which has really harmful implications for somebody seeking telehealth abortion. They potentially would have to get a second opinion, which could cost money. They could potentially be under the cutoff date, but just believe they're not and have to continue on with their pregnancy, which has extremely harmful implications later in the life course, as discussed in this amazing study done by Answer called the Turnaway Study. I will not get into it now, but I highly recommend looking into it, or we can talk about it later. And they also may misdiagnose ectopic pregnancy during the ultrasound, which is not only extremely psychologically aggressive, it can lead to a lot of fear, as it's a very intense and severe, wow, I'm so sorry. Really, it's a really big deal to have an ectopic pregnancy, but also can lead patients who are seeking telehealth abortion to be deemed ineligible for medical or telehealth medication abortion. So those are really big implications of ultrasound use as CPC. So I kind of looked at all of these facts and all of these gaps left in what I'd learned, and I decided that I would propose a new study objective to understand pregnant people's experience with the receipt of pre-abortion ultrasound at crisis pregnancy centers and its impacts on their abortion care and the long term. So this study is a qualitatively designed study that would use semi-structured interviews to answer these questions. Participants that would be invited to take part in the study would be recruited from the chat study that we had already used for the first iteration of this data. They'd be compensated $30 each for their participation, and they'd be eligible if they took part in the chat study and received care for one or more crisis pregnancy centers, but also received an ultrasound during their visit. Our goal would be my goal would be to obtain 25 60-minute in-depth semi-structured interviews that would be conducted by the primary investigator, in this case, me, and over 6 months. And so the outcome would be an academic manuscript that, as well as informational briefs that are written in plain language to relevant allies across the United States. In the questions, we would hope to ask participants to describe the reasons they chose a CPC, the encounters they had as CPC, and whether they asked for an ultrasound or if the ultrasound was kind of given to them, the reasons for the ultrasound that the CPC gave to them, and the impacts of seeking CPC care on themselves and their abortion trajectory, including if they ultimately received an abortion, because not all participants of the chat study ultimately decided to go through with their abortion, but the reasons behind that we could still extrapolate further. And in terms of data analysis, we would use thematic analysis, which is, team-based coding and a mix of inductive and deductive coding, which is kind of the norm for this kind of analysis or these types of questions. Here you can see a timeline associated with this idea, this grant. Pending IRB approval, it would be a relatively short study given the small pool, and data collection and recruitment could happen in tandem with a little bit of ample time for analysis and output of the data. And so the implications of these findings are that we'd be able to provide insights on ultrasound experiences for pregnant people who are seeking abortion at CPCs. And not only that, be kind of able to educate individuals across different locations on what to expect from a CPC further. A lot of the colloquial talk about CPCs is that they're dangerous, but it's not necessarily clear to everybody why. So that is something that could come out of this. We'd hopefully be able to enhance political discourse on CPCs, especially as we see funding for CPCs and reliance on CPCs being most dense in areas where abortion regulation is the most extreme. And we'd be able to hopefully contribute to addressing the gap in understanding of pre-abortion ultrasound experience that I referenced at the start of this presentation. So that's it for me. I wanted to acknowledge my reader, Dr. Suzanne Bell, who's not here, as well as everyone else on the slide. And these are my references. And thank you so much for listening.
Great job, Sylvie. That was really interesting. And like I said, very timely based on the news I heard this morning. So thank you for that. Anyone have any questions for Sylvie?
Oh, there's one in the chat. From Amy. I'm wondering, given that many abortion seekers don't know about CPCs and end up there unintentionally, do patients in the chat study know or report themselves that they've gone into CPC? Okay, so good question. So yes and no. Some people in the chat study did know they went to a CPC, and so they noted that there were a couple options. There was about 5, but one of these options was also clinic. And as you may know, or as you could maybe infer, it's hard to kind of decipher between what's a clinic and what's a CPC. It's more when you get there, you can potentially figure it out, but it's only after going through it. So I actually went through all those clinics and I combed it to make sure that they were in the right spot. But even though I combed it, it's not necessarily 100% all those individuals who went to a clinic did go to a clinic and not a CPC. So that's reflected in the manuscript. But that's another reason why there is an open invitation kind of in this proposed study for chat participants to come on, because they may have gone to a new location after the fact for another ultrasound and realize, oh, I did go to a CPC and I didn't know. So does that answer your question? Yes. Thank you, Mom and Anna. Okay.
It looks like
awesome.
Colby and Rachel have questions as well. Colby, you want to go first?
Sure. Great presentation, Sylvie. That was awesome. It was a point you had mentioned way in the beginning about the number of women receiving non-medically indicated abortion or ultrasounds. And I was wondering, you had mentioned one of the points was that there was a lack of education. That was one of the reasons that you were seeing for that. Was it a lack of education and just that they got it and they didn't know, or was it misinformation that they thought they were doing the right thing based on, we're seeing a lot of resources online trying to prevent women from getting abortions, saying they need to do all these steps. So was it that they didn't know and they just ended up getting it, or that they actually were intentionally getting it, but they didn't need to? Does that make sense?
Yeah. You mean just like an overall an ultrasound? Yeah. So it's actually, so this is the thing about this space is that it is so kind of like I think Rachel said, it's understudied, like it's kind of sad how little knowledge there is. And it's also a deeply clinical space. So there's not a lot of like attitudes papers or like anything discussing the attitudes. So we've kind of had to just infer that people maybe wanted to make sure they were doing the right thing for whatever reason. We didn't necessarily come to any conclusions as to why if they thought they were doing the right thing, or the more personal why. It more was just like, I wanted to, like, for the why of these questions, a lot of them also ended up being like, I went to the doctor and they gave me a routine ultrasound and that is what happened. Or I had an issue like where I just knew, like I had like pregnancy symptoms, and so I went to the doctor. It kind of seems like potentially, and obviously this is not significant, but maybe there is just like a skipping of pregnancy tests, and something I discussed with Dr. Bell, my reader, is like potentially a lack of trust in the pregnancy test, or a lack of provider believing in last menstrual period date and things like that. So there's a lot of room for continued exploration on that front, and hopefully that will happen in the future.
Awesome. Thank you.
Of course.
Great question. Rachel, go ahead.
Great presentation, Sylvie. Really interesting work here. So I have a question both about the formulation of this grant proposal and then also the future of it. So is this just a novel idea you had based on looking at the data at Answer, yeah. Where it just came to you because you saw how many people were going to crisis pregnancy centers, or I'm curious about the inspiration. And then also, do you plan to move forward with this? Do you plan to actually submit this, or in your future career, keep it going within your research, or are you kind of just, master's essay turned in, I'm done?
Thank you for those awesome questions. So first of all, the inspiration, I think that I, maybe like some people here, I didn't know about crisis pregnancy centers till last year. And so I think when I found out, and I would say that I'm pretty well versed in the space, much like maybe many people here. So I think that just the emotional reaction I received when I saw that 15% of individuals, of a pretty substantial size, like pool, I'd say, went to get care there, I was definitely interested. And then the kind of the outcomes of the study or the data analysis that we found, that was like kind of one of the big questions. There's a question of why are, more marginalized individuals the ones who have to go get these ultrasounds, or what's going on there, but also why are so many people going to a CPC? And so I think that this was just kind of a natural question to expand upon, given the fact that given the fact that there's so many CPCs across the United States. And this study, the chat study, largely was looking at California, and a couple people in New York took part in it. So I just figured it was a little bit more robust of a question. And then, or like potentially has more applicability down the line. And then in terms of what I want to do with it, I mean, it would be so awesome to move forward. Obviously, in this context, like that would have to be specifically with Answer, and that is not necessarily something that I've brought up to my preceptor. The current manuscript that I was referencing is about to go out. It's been a really long time in the making. So yeah, I would love to give it to them, or work with, like, not give it to them, but like work on it. But obviously that takes time, and so it might just have to be on the back burner. We'll see. I'll keep you updated.
Great questions. Yeah, the story I keep referencing was about state and local funding for crisis pregnancy centers and how that's expanding in some states. So I think this proposal could be very relevant moving forward should these be expanded. So hopefully it will eventually, progress forward. So each presenters had their 10 minutes to present and their 5 minutes to answer questions. We do have the Zoom room until 1:20. So are there any kind of final questions that anyone has for any of the speakers before we wrap up? We could also end a few minutes early, but we could keep going for sure. Each topic was unique and really, I learned a lot today from all of you. So I really appreciate everything that you put into these presentations. So.
Likewise, this was a really interesting set of presentations. Thank you for them. Of course, I knew about 2 of them in advance, but
I'm going to reiterate that. I learned a lot. I always learn a lot from students. So thank you all very much. Well done, all of you.
Yes, definitely. And I heard a little bit about everyone's kind of future directions, and I'm really excited for all of you. And graduation's in a few weeks, and so this is a really exciting time. So so I guess with that, congratulations to all of you. Wonderful job. If anyone would like to follow up with any of the speakers, we can certainly arrange that. And again, great job, everyone. Have a great rest of your day.